Okay, so let's gain your attention. Does that make you feel a little dizzy or imbalance or probably off a little bit? If it is, then you probably might be my patient in the next 10 to 15 years. If not, you're good at least at this point. So I'm going to talk about the role of audio-vestibular specialist in vestibular diagnosis and management. I think it's very relevant to the existing scenario. And so this is me, because we have a good topic, I'm going to skip that. So to highlight the importance of the role of the audio-vestibular specialist, I'm going to utilize 3 different real-world situations to explain why it is really important. Out of these 3, the first one that I'm going to talk about is a patient that has diagnosed as vestibular migraine and then as a psychogenic patient for over 2 years, and then the second one is Meniere's disease for 14 years, and then recurrent VPPVs for 2 years. So in this particular presentation, I'm going to talk about why and are these interpretations are really the appropriate diagnosis. If not, who and how can we actually come up with appropriate diagnosis? So as we are in the theme of RRR, why don't we actually use RRR to actually fill up some Josh, right? So let's use this because I think many of you feel like the vestibular is complicated, right? How many of you feel the vestibular is complicated? I see a few hands. Probably other might not even aware of vestibular system, but yeah, even for me, vestibular is definitely hard, even now, because we still don't know too many about vestibular system. So first, let's get into the story, the first R of RRR. Yeah, I'm going to use this particular pride of India, the Natu. Because vestibular is hard, let's make it simple and fun. So let's first understand how the vestibular system works. When I say vestibular, I mean actually balance system. Vestibular is major portion of the balance system, but actually we have to refer it as balance system. So here, because the picture is small, I'm referring to the ear, which is vestibular system. Vestibular system is the predominant sensor that provides the overall balance information to the entire body, obviously the midbrain. And then we have oculomotor system that constitutes a reflex called vestibulo-ocular reflex. Okay, I'm going to demonstrate now. And I want you to repeat with me. If not, I'm going to point out everyone. So I have vestibular system, right? And I have my oculomotor system. Let's see how the vestibulo-ocular reflex works. When I'm looking at you, I'm shaking my head, but I'm still looking at you, right? So the vestibular system is working with my eyes parallelly. It's actually moving opposite to each other. That's how I can actually look at you, and this function is called as vestibulo-ocular reflex. That is the predominant sensor that makes us feel stable. If I'm standing here, you're sitting there without falling down, you have to thank your vestibulo-ocular system. Then the vestibular system, obviously, and after that, you have something called cervical system, my neck, right? So I have sternocleidomastoid muscle. Every time I move, not only my head is moving along with vestibular system, my eyes might be actually moving with it, and passively my neck muscles are also moving. That also provides information to the vestibular system as well as to the brain. And this system is called as vestibulo-colic reflex. The cervical system and vestibular system jointly functions as vestibulo-colic reflex. Then we have obviously vestibular system and associated with spinal system. So when I'm standing right here, I'm actually going to move. Standing like this, moving around, but I still didn't fall. It's because that my vestibular system is detecting moments along with my spinal cord. It measures the weight that I'm shifting from one foot to other foot. So that's the vestibular spinal system and called as vestibulospinal reflex. You have to remember all these because you're going to answer me some questions in the next few slides. So please pay attention. Along with these systems, there are more complicated system, which is proprioceptive. So the proprioceptive is an amazing sense, and it should be actually referred as 7th sense because it can detect your anything. It's like your entire body has sensors. It can detect humidity. It can detect that you're actually standing on a hard surface or on a wet surface or even grass, everything. So that is proprioceptive system, along with obviously vascular system. And there are other systems that include central system. So these constitute the human balance system. To learn just this, you probably might need to spend at least 2 different semesters, but I summarized in probably a couple of minutes. Let's actually use these systems. Okay, so now you're going to answer me which system is actually actively working on. Ready? Here we go. Absolutely right. So vestibulo-ocular reflex. Does anyone have any question about this? It's an amazing step. So head motions and along with eye motions, and they are standing with even though one leg, but they are still standing, but they are not actively moving. So there is spinal reflexes actually working, but the dominant one is vestibular and ocular. That's the right answer. So vestibular ocular reflex. And usually this vestibular system is around 60% now. Oculomotor is contributing around 30%, and central system is around 10%. Again, it's average. We can debate on this, but I'm not going to answer that. So let's look at this again with a second perspective. Same step, but what is the passive system that I just explained? Vestibulospinal, cervical, thank you very much. Cervical, right? So the neck as well as the head is moving. So obviously it has like a more than 3, but vestibular system is 60%, and cervical is now I'm going to say about 30%, and the central system is again 10%. So vestibular colic reflex. So now let's look at this one. Wow. Which system is this? Spinal, right? So thank you very much. You're making my day. Vestibulospinal, because we are using vestibular system, but little bit, because they're jumping, right? So the utricle and saccule is actually moving. So there is still 30% contribution, and the spinal reflexes. It's an amazing step actually. You need a lot of practice. So it's a 50%, and along with that, if you can notice, the central system is contributing a little more, because it has to actually integrate the information coming from vestibular system and then with the spinal system, and the other hidden information here is actually the proprioceptive. Let's watch this particular step. How many systems? All the systems, right? And we should be really amazed, just like that guy actually. So to perform this step, our regular vestibular system and human balance system is not really sufficient. You have to fine tune it. You have to actually improve your vestibular system along with your overall spinal and other balance systems. So that is the beauty of vestibular system and human balance system. Unfortunately, that brings and even makes it complicated, because when it comes to hearing, you know that it's outer ear, middle ear, inner ear, and then all the way to central. That's simple for us, right? But when it comes to vestibular system, now we see there are too many systems that's actually involved. And there are a few more systems that I couldn't even show you, like vascular and other stuff. It is complicated. So the problem is, the problem also comes with the beauty of anything. So beauties are also a problem, right? So let's watch this video. Let's see what happens to this third person. He fell down. What could be the reason? Could be any of things. It could be vestibular, it could be ocular, it could be spinal, it could be cervical, it could be vascular, it could be other systems, or it could be just functional, like tired. He's tired, probably haven't eaten food, or probably didn't have enough water. All these factors contribute for vestibular issues. Have you heard recently, like many people are actually complaining about vestibular issues, even young generation, and we really don't focus about it. I don't see why people are actually talking about it. We have to, right? So when it is abnormal, you have to suspect too many things, and unfortunately, that is not the case. People take it as very simple. Anything can go wrong. It can be ocular system, it could be spinal system, it could be cervical system, it could be just the psychological, right? So we're done with the first R. Now let's get into the second R, which is the problem. The problem is the lack of audio-vestibular specialists. Again, I'm not categorizing another audiology group, but I'm going to try to highlight the importance of audiology specialization into the vestibular. There's a reason why I'm referring it as audio-vestibular specialist, and I'll answer at the end. So this particular patient, I'm going to utilize this patient to highlight the importance of the audio-vestibular specialists. This particular patient visited a neurologist with an vestibular setup in their hospital. This patient has been diagnosed with vestibular migraine and then later point psychogenic. I'm going to skip because we are really lagging at the time. So this assessment has been done with the help of technician. Again, we're getting into that field. Even though we have good amount of audiologists, we are not really paying enough attention on vestibular, so now is the time. So, okay, the diagnosis was made as vestibular migraine, and I don't know whether if you observe, a lot of neurologists actually love to diagnose vestibular issues with this client. Then later, which is exactly what happens, because these guys put on vestibular migraine medications and others, finally they frustrated. Now they feel vestibular issues every time. I get up, oh, I feel dizzy. I sit up, oh, I feel dizzy. I eat too much, I feel dizzy. I eat spice, oh my God, I feel dizzy. Everything is dizzy, 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 and now this guy is categorized as psychogenic. And vestibular migraine, vestibular suppressants, broaden is, oh my God, that's a pocket chocolate in India. Spin-free and SSRIs, nowadays it's getting fame after broaden. Look at the DHI. The DHI is dizziness handicapped inventory. This particular patient is on medications for 2 years. And the DHI, the higher score indicates the worst life, is living in a hell after 2 years of treatment. Why is this? Let's see what happens if this patient could actually visit a proper audio-vestibular specialist, such as probably, let's say, take it as Aish or probably enhanced, which is this team as led by actually audio-vestibular specialists. So they went through like regular VNG evaluation. I'm not going to explain everything. It takes a lot of semesters for you to understand. But these are the tests that we commonly go through during VNG evaluation. Everything come out to be completely normal up to the VNG evaluation. Let's look at the caloric test. This is a caloric recording of this particular true patient. Indicates a borderline right weakness. If you only look at this caloric and if you're really not confident with your vestibular testing, you may say it as actually normal. And I cannot debate with you because it's still borderline. It is truly borderline. It's only 30%. And if you don't have VEMP at your clinic, you really don't have any further evidence. If you're thinking about vestibular, add VEMP. It really helps you in diagnosis. So look at the P1N1 amplitude. It is weaker on the right side, and it is supporting now with much evidence to the caloric, which in this case is weaker. We have weaker evidence, but caloric is, the VEMP is actually adding further evidence with 44% of weakness. Now, the weaker becomes stronger evidence indicating that there is actually weakness on the right side. So was it really vestibular migraine or psychogenic? No. Who made this change? Not the audiologist. No, I don't agree. I'll show you the reason why. You have to be audio-vestibular specialist or audiologist with a vestibular specialization. That is what I really want. So let's look at the other evidences that truly adds. I'm not going to explain what these are. It's a rotary chair results, which is the beauty of the test that actually gives you even further information, adding whether if it is actually compensated or compensating or not compensated. So this is indicating that there is a borderline low gain at the low frequencies, indicating that it is actually compensating. Thank goodness for this patient, he is actually recovering, not because of the medications. The medications in this case has delayed the compensation. If you had a severe vertigo, one of my best suggestions is actually try not to visit anyone for the next 1 week. You will recover. Your vestibular system has amazing way to recover within the next 10 to 15 days. But you need help to not get into health, which is triple PD. I'll talk about that later. The SHA is the sinusoidal harmonic acceleration. So that's one of the testing. We'll talk about that when you see me the next time. So these are the test results that actually indicates that this patient has true vestibular weakness and it is compensating. Thanks to the vestibular medication, it took 2 years to actually still get into the compensating stage. Otherwise, this patient would have been completely normal. I'm being very honest actually. If this patient hasn't been visited to any physician that has actually prescribed broaden, he will recover within the next 15 days and he can go and do most of his, probably 40 to 60% of work fine. So, test results. Caloric indicating 30% weakness, rotary chair, adding further evidence saying that it is actually compensating, not just saying that it's weaker, but it is actually compensating, and CWIMP adding more evidence saying that yes, there is actually weakness. And unfortunately, the DHI is actually 88. How? So neurologists couldn't help. And just now, audiologists actually find out that it's actually because of hypofunction, vestibular hypofunction. What else should we do to actually improve, even after 2 days, 2 weeks, or 2 years? So let's find out this test, which actually tracks not only how works the vestibular system and other parts of the systems, and it also helps us in understanding whether the patient is actually showing progress or not. It's a very simple test. You don't need actually equipment. If you know how to do it, you can do it at your clinic without anything, just by having a foam pad. So this test is very simple. The first one is standard, meaning that I'm activating my all senses: visual system, vestibular system, spinal system, and even proprioceptive. So I give everything. I just ask my client to just keep looking straight, focus on my voice. And if this patient actually moves, then I know probably all of his senses, a few of his senses are actually affected. That is standard in the first step. This patient showing a very significant abnormal responses, even in standard. Second one is proprioceptive. I just ask this client to actually close his eyes. So when we close his eyes, and I'm not actually moving this client, right? It's just stable. So vestibular system is not activating. It's just stable. It's not moving. So vestibular system is off. Vision is off. The sense that he's relying on is proprioceptive. It's not moving, not dancing, right? So it's not with spinal, but it's just the proprioceptive. And even in this, you're looking at poor results. Okay? And with the vision open, and I used foam. By taking foam, I'm eliminating the proprioceptive. So now the proprioception is gone. He has to either depend on vestibular system or vision. That's exactly what we're actually looking at. The predominant one is vision. So even in this, he scored very poor. Let's look at the vestibular. Now I asked him to stand on the same foam pad and closed his eyes. So now he has to rely on vestibular system. So very poor. If you look at all the results, in every aspect, all 4 senses, he could not actually rely. Why? But in previous test results, what we saw is vestibular weakness on the right side. But here, he couldn't use any of these systems, or it's showing as completely abnormal. Any ideas? Hypofunction is the actual reason. Because we put him on medications for a very prolonged period, we are suppressing the senses, vestibular suppressants, and that induces triple PD, just saying to your brain that you are weak, you are weak, you are weak, you are weak. And now, even though he's actually off the medications, his senses are weak. It's like I haven't walked and I haven't run for like years, and now if you ask me to run, I go there and then that's exactly what's happening with this system. So every system has been affected. Let's focus on the actual treatment that this particular guy needs. Before that, let's put all these pieces. That's where you, any audiologist that's looking into vestibular specialization, come into role and put all these pieces together and come up with the appropriate diagnosis. Right vestibular hypofunction, and based on the MC, TSIB, now you know it is also the triple PD, because the other senses are also fine, but we made the other senses weaker. So now we have a bigger job to actually improve these senses. That is exactly what we have to work on. Why the difference in this diagnosis? This patient has dealt with audiologist and neurologist, but unfortunately, even with VNG evaluation, we could not find the appropriate results. The reason is that there is no proper vestibular and balance specialization. We really do not have enough specialists in this. I get patients, I get calls from different countries and different places, and people travel all across from different countries. Do you understand the importance, and do you know how it feels actually? That actually feels like hell. They spend more money than your hearing aid actually. How much it makes a difference in patient's life, a life-changing difference. And why no improvement so far? Because of the misdiagnosis, and the core reason is really do not have enough specialists. And whoever that we have, either is a technician, probably 10th pass, or probably so and so, or we do not have enough knowledge. And this is where I'm going to actually urge all associations and institutes to actually start looking into vestibular. This is the time that we actually expand audiologist scope into vestibular, because this is the another future. So, treatment and outcome. Without treatment, there is no point of doing all these things, right? We just used a traditional VRT program, specialized, and we first started actually working on the triple PD, not on the hypofunction, because without the senses, without the patient realizing that I have all senses fine, but it's just that I haven't been using it, right? So we started using this VRT, traditional VRT, nothing fancy. Within the 6 weeks, you see the difference in the standard. Now he's utilizing all senses fine. Now when we're doing this test, he's completely fine. And proprioceptive, because his proprioceptive system is completely fine, now it actually came back. And vision, yes, he doesn't have any blindness, so it's completely fine. But it's only 6 weeks. It's only 6 weeks. After 2 years of medication, he has recovered his 3 different senses. And now he can come to completely fine in most of the scenarios. But during complex situations, which is in vestibular, such as like turning quickly or probably standing up quickly, induce a little bit of imbalance issues, but that has been taken care probably in the next 6 weeks. We already took care of this patient, but I don't have updated information. What are the treatment strategies that we followed? We really did nothing fancy. It's basic idea that, okay, now we know what happened. We first limited vestibular suppressants. He was still using actually after 2 years, just limited vestibular suppressants, and then gradually reduced SSRIs. You cannot stop SSRIs immediately. And we actually first started with the traditional VRT, focusing predominantly on the triple PD, and then VRT. And finally, some advanced virtual reality to actually overcome the triple PD issues. And this patient is completely happy now. Happy story. After DHI, 6 weeks, just within 6 weeks, as you can see, a significant difference. That is what you can give a life, happy life to a patient. That's the change a vestibular specialist in vestibular specialist in audiology, or audiologist in vestibular specialist can provide. Let's just see the second one. This is where I'm a little guilty actually. The second patient actually visited to audiologist. Babu, laddu aa gaya. So this is what we feel, right? Most of audiologists, when I see like audiogram with hearing loss, okay, now I have a laddu, in case there's 2 laddus. Unfortunately, that's exactly what happened, even though the patient complained about oral fullness, tinnitus, and fluctuating hearing loss. At least that's what the patient mentioned to me. This patient was, unfortunately, this audiologist is actually intelligent, that he did actually get medical clearance from ENT, and then he fit hearing. He was doing the right thing. He did actually send to ENT, but unfortunately, they did not consider the vestibular evaluations. The patient was not really happy with the hearing aids, and because it makes him feel uncomfortable, and the hearing loss is actually fluctuating. Then he visited to another ENT with the vestibular setup. Again, had a technician, not audio-vestibular specialist or vestibular audiologist. So, diagnosed as Meniere's. The history is very classic: oral fullness, tinnitus, fluctuating hearing loss. I've seen many ENTs love whenever they just see these symptoms. No recommendation, no tests, nothing. Meniere's, put them on vertiges. And diagnosis as Meniere's CHAMP test. CHAMP is gone. But I have to do something, and we have to do something to actually inform ENTs to actually stop referring for CHAMP. CHAMP is not in production anymore. That test is gone. It's not widely accepted. But still people go for this, and I never seen a proper CHAMP report yet. Please educate your clients and any associated doctors that CHAMP is not to go test for Meniere's. Please. So VNG responses, they did VNG and CHAMP turned out to be positive, but the report is crap. I'm sorry to say, but that's crap. And then this patient, the reason that I'm very honest is that this patient was put on, I could actually sue all of these people, put on diuretics, steroids, migraine medications, vestibular suppressants, routine, spin-free for all 12 years, and then SSRIs. And still after 12 years of several treatments and everything tried, DHI is 72%. What would we do? How can we change this? Let's bring this patient to audio-vestibular specialist and see what we can do here. These are the tests, the spontaneous nystagmus. Still after 12 years, there is a spontaneous nystagmus. Those who know vestibular system, you know how terrible it will be actually. And we know there is something wrong in the diagnosis actually. Head shake, still some right beating nystagmus. You're not supposed to see after 12 years of treatment actually. Calorics, left weakness, 67%. It could be Meniere's, right? I might be still wrong. So what else we did? So we took CVEMP, left-sided weakness, again indicating, correlating with the calorics and other tests. Rotary chair, high gain. That's a huge red flag. And this is how the comprehensive neurodiagnostic evaluation will save you actually in complicated patients. If it is true left side weakness, you're going to see actually low gain in SHA, but here it's high gain. Now there's a discrepancy in results. That is a red flag for the specialist here. Step velocity normal and fast decay, which means actually peripheral. ECOG is normal. CHAMP was actually abnormal. That's the reason why they actually diagnosed as Meniere's. Now with this comprehensive evaluation, I don't think any vestibular specialist would actually diagnose it as Meniere's. Now think, if you are the patient that went through diuretics and Meniere's medications, migraine medications, suppressants and all those things, how furious would you be after receiving that all of your diagnosis is wrong? Forget about the furious. 12 years of his life. So this is the audiological evaluation. Completely fluctuating, and he's still yet on the hearing aids even with uncomfortableness. If you put all those three audiograms just in one, what would you really see? The first thing that you learned, I think in your second BASLP, asymmetric hearing loss, is a red flag. That is exactly what we have. And unfortunately, all those three audiograms did not accompany with speech audiometry. Question you 6 years of degree and why you're not actually doing speech audiometry, right? This is a classic red flag, asymmetry to speech audiometry. This is exactly what you get. It's not Meniere's. We forget what we had. What are the red flags? Asymmetric hearing loss, poor speech course in the worst ear, and pulsatile tinnitus, another red flag. High gain in rotary chair, all are retrocochlear indicators. What did we do? We did send him for a medical physician, specially indicating that we need imaging. So, putting all these pieces together, bilateral, so caloric indicates hypofunction, left weakness, and rotary chair is actually contraindicating, which is indicating both central as well as peripheral. That is exactly what we had. First, we indicated as vestibular hypofunction, considering all those tests, and MRI came out, indicating that's actually IAC, vascular lobe. Artery compressing the auditory and vestibular now. Not Meniere's. The actual diagnosis is left vestibular hypofunction, which is paroxysmia, secondary to the vascular loop in IAC. This is very, very important to actually treat this patient. Whatever the diagnosis is, you have to treat this patient. So how did the treatment look like? Simple. We sent to vascular specialist. Now he's on blood thinners, on cholesterol medications, now under observation for vascular decompression. Vascular decompression is a very complicated surgery procedure, so we haven't considered that yet. And vestibular rehabilitation, because he's going through hell for 12 years. Obviously, he's on triple PD signs as well. So we did utilize vestibular rehabilitation to promote balance and progressive tinnitus management for tinnitus, because that is also terrible in vascular loop conditions. Change in lifestyle. So reduce movements that actually compresses any portion of the arteries that are actually extending to the brain, because that can be life-threatening sometimes. So DHI outcome, after just the diagnosis and sending him to the vascular specialist, putting on those three medications, changed his DHI. Not even with VRT, actually, just 2 weeks or 3 weeks of VRT actually, not even 6 weeks. I'm pretty sure about this patient. Third patient, visit to one of the biggest corporate hospital. Unfortunately, even these guys do not have audiologist or vestibular audiologist as the specialist, but had a vestibular technician. Recurrent BPPV. This patient is 67-year-old, had a history of trigeminal neuralgia, severe spinning sensation post-surgery, and every time he feels vertigo, like whenever he changes his head motions, and increases in severity unpredictably. Treatment, diagnosed as complex and multi-canal BPPV because of multiple recurrence, and Vertin 24 mg twice a day, I think more than 6 months when we saw. And CRT maneuvers was implemented for both anterior, posterior canals. And he was recommended to actually do home-based BBQ roll every day, twice a day. So, their vestibular evaluation, again, left side BPPV and AC BPPV, recurs even after that. And again, after that, this patient is put on vestibular suppressants. And this signs actually recurs every 2 to 3 days. Anyone that actually doing BPPV, and even with common sense, if a BPPV is recurring every 2 days, do you really think that it is BPPV? No, right? If something doesn't fix, why do the same thing? Unfortunately, this has happened from too many times. So that's the case with this. So we should have actually opened our eyes, or probably brain, to actually look into why it has been recurring. But unfortunately, that didn't happen. I'm not blaming anyone here. I'm just advocating that we need more specialists. Let's see what happens if this patient actually visited anyone that has vestibular specialization. So initial visit, obviously, if someone shows any signs, we do need to look into all these positioning tests. Even we found that there is actually, it's negative for BPPV, but it seems like there was a lateral canal BPPV. And it did actually fix on the same day. But the second time, he was actually complaining that, again, the signs have changed. Considering this, I would be fool again if to consider BPPV. So we changed the pattern. Now we get into comprehensive vestibular evaluation. What did we find? Too many things. Too many abnormal, and the predominant one is VBI screening, vertebrobasilar insufficiency. That actually indicated there is actually right side weakness, and vascular screening also indicated there is actually weakness. Caloric indicated weakness, and WEMP also indicated weakness. With just this report, you would be actually diagnosing it as right side weakness.
We are running out of time.
Sorry, I'll be very quick. Sorry. Okay, so skipping this apart, the actual results came out to be very, very frustrating and actually dangerous. So this patient, again, we sent to get the imaging studies, and CT venogram of brain has been conducted and found out that's actually atherosclerotic internal carotid artery with calcification, meaning that the artery is calcified, that blood is actually not passing to the brain. And this patient has been instructed to do the BBQ roll every twice a day. You're asking to compress the artery that's carrying blood to the brain. You're putting the patient in risk. The patient might actually get the stroke or even may fall down to death because that we're actually compressing the artery that's carrying blood to the brain. And because of that, this patient also resulted in insufficient oxygen supply, so hyperintensities in MRI. Anyway, so putting all these pieces together, it's a vestibular hypofunction post trigeminal neuralgia with vascular involvement, obviously atherosclerotic internal carotid artery with calcification. It's a very dangerous. So BPPV seems very simple, but if it is recurring and it's not fixing, we have to be very careful. So again, refer to vascular specialist, cholesterol medications, and in observation for carotid artery stenosis to prevent any life-threatening issues. And vestibular rehabilitation has been done to promote compensation. He's definitely doing better now. And change in lifestyle is very important, and he has to definitely prevent any motions or any position that compresses his neck. So meaning that no BBQ roll or any CRT maneuvers. So coming to the last R, I'll be very quick. The role of the audiologist and the vestibular specialization is too important, and that is the reason why these, not just these three patients, I have so many horror stories. Why is this? It's because the system is really complicated. It's not that easy. And if you can see, Vestibular system comes under us and ENT. The spinal system comes under probably neurologist and other specialists. Cervical probably taken care by mostly physiotherapists, and oculomotor system probably other specialists. Does any single specialist work on all these things? No, that is the primary issue. We think the vertigo or imbalance probably is coming from vestibular, or probably it's simple. It is really not. Because of this complexity, we need complex education, complex knowledge in it. And that is what I'm actually trying to advocate for. Okay. So this is the effect of audiologist. I'll be very quick. The effect of audio-vestibular specialist on the diagnosis has changed. The diagnosis obviously resulted in a better management for these, has changed their life, truly life. So all three patients, amazing. I'm going to show you a quote. So this wouldn't have happened without VRT. With just diagnosis, you're not going to change their life. You need to have vestibular rehabilitation. You have to understand each patient needs specific vestibular rehabilitation techniques, like art. It's not something that you see in YouTube and go for a therapy. It's not like a speech therapy online. You have to assess based on the client. Unfortunately, this is unpublished stats. The peripheral vestibular loss patients are actually on vestibular suppressants, 72%. And this is the first thing that we should not do. And unfortunately, 72% of the patients are on vestibular suppressants. And the remaining 28% are following brochures or probably YouTube videos. So how can we fix this? Obviously, we have to focus on VRT, and to recover the lost balance, either you lost the vestibular system, you lost the cervical system, you lost the spinal system, the other systems can actually compensate. That is the beauty of the balance system. Even though it is complicated, you can change a 90% of the patient's life for better. Okay, so any of these functions is gone, you can actually recover. It's a loop because of this particular lack of audiovestibular specialists and lack of appropriate treatment or VRT strategies, and no multidisciplinary approach, and lack of neurodiagnostic evaluation, and unavailability of vestibular specialized clinics or centers, and lack of patient and physician awareness is leading to this, a loop. So we have to try to break it, and I think it should start with audiologists. Otherwise, we're going to entertain more quacks and more technicians taking out your jobs. Try not to just rely on hearing aids. You know what? This patients, if you change their life, they bring you more hearing aids patients and more hearing loss patients to your clinic because you change their life. So that's the end. And this is a quote directly to me by a neurologist. Usually patients treat doctors as gods. But for doctors, if you the audiologist, help with vertigo, you will be the super god to the god. Super god to the god. Quoted by a neurologist named Hyderabad, because she had BPPU, true recurrent BPU, multi-canal, but she was on Vertin for a prolonged period. Just changed it, and this is exactly what we can do. Let's join hands.
Thank you so much.
To create more audio-vestibular specialists. Thank you very much.